So
Okay.
good evening, everyone. We are doing our first ophthalmology webinar, and I have with me here Dr. Pei, who is actually my colleague from Sunway Medical Center. Dr. Pei is actually started off as you didn't start off as an ophthalmology fellow, right? You did what, orthopedic?
Yes, initially I did, yes.
So what made you change?
It's short. I mean, in short, I couldn't take the hours.
Oh, I see.
Orthopedics, trauma orthopedics is quite intense in the UK, especially over the weekend.
Okay.
Yes.
No
So I thought I'd try something completely different, and I think change is good once in a while.
Yes, and glad you start us with the ophthalmology, and now you're here with us. So without further ado, we go ahead with your slides.
Okay, so yeah, is that good?
Okay, it's good.
Okay, evening everyone. Thank you to Dr. Betty for for this seminar. So allow me to introduce myself. As Dr. Betty mentioned, I am actually, or did she? I completed my undergraduate training in the UK as well as postgraduate training. So I've yet to, and I worked in Singapore for 5 years prior to starting at Sunway Hospital in the middle of the pandemic. So I've yet to meet many of my peers locally. So hopefully this will allow me to engage yeah. So below are my financial declarations. I have received sponsorship and honorariums from these companies. So blurry vision is one of the commonest symptoms that presents to an ophthalmologist. In tonight's seminar, I will cover the commonest causes, discuss the treatments, and along the way, I will also show videos of eye surgery, although I will give advance warning if there are sensitive viewers. Throughout, I will also introduce equipment that I think have really changed modern ophthalmic practice. So when approaching a patient with blurry vision, I start with the basics. First of all, how bad is it? So objectively, we quantify vision by measuring visual acuity. So this is a chart that we are most familiar with, the Snellen distance chart, which is usually standardized at a testing of 6 meters or 20 feet. We also use a near reading chart for close vision. And to all attendees who are trying to test their vision right now, just take note that these charts are not to scale. So don't worry if you can't read them. So actually, there are many other aspects to what we globally call vision. We can also quantify color vision with Ishihara plates and contrast sensitivity with the Pelly-Robson chart. Subjectively, there are also Emsler grids to examine the central visual field and Humphrey visual field tests to examine the peripheral vision. So after finding out what aspect of vision is affected, standard questions about any disease symptoms are asked. How long has the blurry vision been for? Is it constant or intermittent? Does any particular activity make it worse? And especially in the case of eyes, we need to know how it affects one's daily life or even job. Very relevantly in today, does the person drive? Do they drive a lot at night? Do they read? And if so, usually on what sort of platform? Is it from print or do they read mostly from devices? So when thinking about the possible causes of blurry vision, I actually find it helpful to first think about the eye as a camera system. The eye is essentially a biological camera that takes a photograph. This photograph is then transmitted by our optic nerve USB cable to the CPU, known as the brain, where it is processed. So quite simple if you think about it. Further variation is that most of us have two cameras, so two eyes. They take slightly different pictures of the same image, and the brain integrates the two disparate images. And this is what gives us stereoscopic vision. Additionally, there is also input from our ears, our inner ears act as internal gyroscopes. And most importantly, there is a psychological component to vision. It can be affected by emotions and memories, So hence the term, our mind is playing tricks on our eyes. For example, it is very, very often, patients present with blur vision, and we have to ask them which eye is actually the blurry one. A patient could say the left eye, but then if they occluded their left eye and just looked with their right, it could just be the left visual field of their right eye, if you know what I mean. So it's a very clever apparatus. And so we'll examine the problem in this order, starting with issues to do with focusing of the camera. Then we move into the structures of the eye, the cornea, the media, which are the lens, the vitreous, before examining the retina. So the first approach is to ask if light is being focused. So human beings are not homogeneous in size and shape. Whether the eyeball is too long or too short will affect its refractive state. So the next question is, are they supposed to be wearing glasses? A lot of us are supposed to be wearing glasses, but we don't for various reasons. The most common refractive state we know of, and that is most common in Orientals, is myopia. So it is known as short-sightedness because the image that is focused from a distant object falls short of the retina. So in patients as such, they need a concave spectacle lens to push the image back onto the retina in order to focus it. On the other hand, if someone did not need glasses, it could mean that light from a distance is either focused directly on the retina, meaning the person is truly ametropic or neutral. But it could also mean that the patient is hyperopic, the opposite of myopia. So in hypermetropia, the image from a distant object is focused behind the eyeball. And in these cases, patients do either one of two things. Either they accommodate, in other words, this is where the lens can thicken due to changes in the lens shape caused by relaxation of the ciliary muscles and inward rotation of the ciliary muscles. And it brings the image forward onto the retina. So this brings us very nicely to the next commonest cause of blurring of vision, which all of us will experience at some point in our lives. We all have a relative who, over the years, we notice is holding their book or their phone further and further and further away until such point that they need binoculars to even see the letters.
Or longer.
So this is, so this is known as 老花眼镜, old flower, as I come to understand. So the thing to understand is this is due to a phenomenon called presbyopia, and it is a normal physiological deterioration in our ability to accommodate. I've been trying to explain this chart to patients, but basically what it is when we are below the age of 40, we have about plus 4 diopters of accommodation. So in other words, if an image fell this far back behind the retina, if we were less than 40 years old, we would be able to bring it into focus. And that would explain why babies are able to focus really up close. But so this accommodative amplitude of 4 diopters actually reduces as we get older. From after the age of 40, it reduces quite quickly down to 3 diopters. And by the time we're 50, it's half to 2 diopters. And if we are 60 years old, it actually is 0. So if someone is long-sighted and looking at something in the distance, for example, if they are plus 100 or plus 1 diopters hyperopic, but at the age of 60 or above is not wearing glasses to look into the distance, they're living by that great river in Egypt. So long-sighted patients, usually as they get older, they need to wear glasses for distance as well as near. Because obviously, as we move the object closer to the retina, the further it falls behind the retina. Whereas for someone who is short-sighted like myself, as presbyopia sets in, our focus point is short of the retina anyways. So all we need to do is just take our glasses off in order to read. So moving on to problems with the eye's medium. We often think that the eyeball structure begins with the cornea, the covering of the eye. But in fact, the eyelids, corneal tear film, and the cornea itself all form a separate organ in itself. Dry eyes is a really underestimated cause of blurring of vision, but it's something we all experience at some point in our lives. The tear film itself is a very complex structure composed of three layers. If you remember our childhood days cycling downhill, what happens? As we cycle downhill, the vision blurs. This is because the air currents will cause the tears to evaporate from the eyes, and it is usually transient and can be blinked away. Activities that require concentration, such as reading, driving, or looking down at an operating microscope, as what I do most of the time, exacerbates evaporative dry eyes. In its most severe form, you can see these tiny little punctate dots on the cornea, which form due to degeneration of the corneal surface. The eyelid also plays a role. If there's any infection, that causes this little crust to form, and it's called blepharitis. And this crust can actually irritate the tear film. And that's why in the treatment of blepharitis, it is also important to prescribe a lubricant to lubricate the corneal surface, protect it, and also it dilutes whatever toxins. The lacrimal gland in our eyes produces tears, which are then channeled by blinking towards the punctum. So tears are channeled in a blink reflex from the outer part of the eyelid all the way to the punctum. And there's an actual internal drainage within here that drains the tears away. That's why when we cry and there's excessive lacrimation, we get choked up because the drainage system is overwhelmed. But in this case, the eyelid acts like a car wiper blade to refresh cornea. So any condition like an outturning of the eyelid, as in this case here, called an ectropion, means that the wiper blade is not working properly. And that in turn can cause the tears to flow down the cheek instead of being channeled across, results in poor retainment of the tear film and causes secondary dry eyes. So the cornea itself is our eye's window. So any abrasion or ulceration can lead to scarring. And if it involves the central visual axis, like here, the covering of the cornea, it can cause severe loss of vision or blurring of vision. Deeper to the cornea, there's an anterior chamber with fluid within it. And sometimes in certain inflammatory conditions, such as iritis, the fluid inside within the anterior chamber can become very turbid and hence cause blurring of vision. But in these cases, there's usually pain in the form of photophobia, as well as when the patient tries to read, because iritis also causes inflammation of the iris, hence the term iritis. And so when we read or if we look at something bright, the iris is trying to constrict. And so it's like flexing a cramped muscle. So that's a feature of iritis is actually pain. The mydriasis can be due to pharmacological causes of mydriasis. So where the pupil is permanently dilated. So this is usually due to some sort of trauma to the iris. It can occur in the setting of a complete nerve palsy, but the patient would also report double vision because of the cranial nerve palsy. Pharmacological dilatation, like what we always do in the eye clinic, can also cause mydriasis, but this is temporary and the history is usually the giveaway. Deeper to the eye, once you're past the pupil margin, lies the eye's lens. So sometimes blurry vision is simply due to the fact that the lens is absent, so aphakia. So in these cases, the blurring is profound, and because the lens is a major contribution to focusing light. So for example, this is a picture of a child who probably had a congenital cataract, which was removed, and probably for various reasons, an intraocular lens implant wasn't placed. And therefore, in order to take on the job of focusing light, this patient has to wear these typical aphakic glasses that we do not see very often in recent years. This is a patient in the middle here. This is a patient who had cataract surgery before, and spontaneously over the years, the zonules that actually support the lens structure has ruptured, and therefore the lens, the intraocular lens implant, subluxes inferiorly. So this is a lens which we can see just behind the pupil. Sometimes if all the zonules rupture, or in the case of trauma, the entire lens can be dislocated into the vitreous itself. So on to cataract. Now, cataract formation is probably what we associate as the commonest cause of vision blurring. Simplistically, think of the lens in our eyes like a cod liver oil capsule. So as we age, or in the presence of certain conditions such as poorly controlled diabetes, the cod liver oil or nucleus becomes cloudier and thicker. At the same time, there is a loss of contrast sensitivity in addition to blurring of vision. One of the earliest symptoms patients can experience is glare from oncoming headlights, and sometimes this is the actual presenting complaint. So this is a slit lamp photograph showing a cross-section of the lens from the front of the eye, from the front part of the cornea to the back. And the central part is called the nucleus. So to those who are interested, I will show a video of cataract surgery. So viewer discretion is advised. Modern cataract surgery actually involves making a small little 2 millimeter incision in the front of the eye here, followed by what we call a capsulorhexis, which is a hole. And this can be done manually or using a femtosecond laser to create a manual hole in the front of the capsule here. I'll speed this up. So then subsequently, once access to the nucleus is allowed, we do this procedure called a phacoemulsification. Essentially, this is a high-frequency ultrasound where the probe is vibrating at a very high frequency, and this causes cavitation of the nucleus, which we can subsequently break up and aspirate. This is the part that is commonly mistaken for a laser, as a lot of times we do this cataract surgeries under local anesthesia, and this machine sounds exactly like what we assume a laser machine sounds. It's a very high pitch. So, but the actual name is phacoemulsification. So the nucleus is broken up and aspirated And at the end, you are left with a nice clear capsule, as you can see here. And you can actually see the patient's floaters floating into view at some point throughout. And once there's a nice, clean and clear capsule, we inject the new lens, which sits inside the capsule and sits inside permanently. So it's really clever, very clever technology. And the tiny little wound there does not need to be sutured. We just pump it up with some water and it creates a self-sealing wound. And in very quick, uncomplicated surgery such as this, so this was timed at about 12 minutes. And the lenses are amazing technology. You have monofocal lenses, which give you distance vision, but patients will still have to wear glasses. So in a patient who has had cataract surgery and complaining of near blurring of vision, you have to ask them, are they wearing glasses at all? And patients can have the opportunity to have a multifocal lens implanted, which gives distance and near visual acuity 80% of the time. So deeper to the lens is this semi-liquid structure that we call the vitreous. The vitreous in our eye is like an appendix, meaning from the moment we are born, it serves no structural nor metabolic function. So opacities in the vitreous usually cause what we know as floaters. This can take the form of inflammatory cells, as what happens in uveitis. It can be blood for variety of reason. So it's usually called vitreous hemorrhage, or even calcific degeneration, as in this picture here. And it's called asteroid hyalosis. Surprisingly, despite such severe asteroid hyalosis, for example, in this patient, you can hardly see the retina behind it. But this patient has 20/20 vision. And I don't really know the explanation for that. So as I mentioned earlier on,
no blurring at all.
No blurring at all.
No shadowing,
Despite nothing. So they don't complain of vision that's poorer than ours, but it does make for certain diagnostic dilemmas. So for example, if you find a patient with severe diabetic retinopathy in one eye, and then you try and examine the other eye, but that eye has asteroid hyalosis, which is more common in diabetics, that makes examining the retina very tricky. Yeah, but the most common thing most of us experience at some point in our lives is this thing called a posterior vitreous detachment. Remember, I said that the vitreous body is redundant. So what actually happens is from the moment we are born and in around our 20s, vacuoles, pockets of will form, and these pockets are filled with aqueous humor. And gradually, that's why we all notice some floaters to some degree, usually in the form of these little squiggly worms or dots and rounds, and especially noticed when we are kind of daydreaming against a very bright, plain background, such as the sky. So beyond the age of 40, what happens is that the vitreous is now so degenerative that the structure simply collapses in on itself. And so it separates from the wall behind, from the retina behind it. And at that point, usually patients will notice a change from these little worms to sometimes they can even say there's a fly. I feel like catching it. So there's this little circle floating around, and that's actually got a name. It's called the Weiss ring. So that Weiss ring is actually what we look for to confirm that the jelly has actually separated from the eye during examination. So patients can get a sudden increase in the floaters. They can get flashing lights. Why is this relevant? It's relevant because as the PVD develops, most of us are fine, but in 1 in 10 patients, what can happen is a tear or hole can open up. And if there's a tear or hole opening up, especially if there is an area of unusually strong traction between the vitreous and the retina, water can enter, aqueous can enter the subretinal space, and then the retina detaches away from the wall of the eye. Depending on whereabouts the retinal detachment is, it can present. So we have to also remember that our retinas are actually wired inside out and outside in. So like this picture here, this patient has an inferior retinal detachment. So the lower part of the retina is detached, and the lower part of the retina is responsible for the top part of the vision. So in someone with a detached inferior retina, they actually notice this dark shadow or gray area at the top. And then what happens is, as the fluid progresses, more and more of the retina is detached, and they will notice this shadow descending. Here, in this case, the macula is still attached, and that's why their central vision is still all right and normal. Now, however, in this patient here on the left, there's a superior retinal detachment. So it's a retina at the top, and you have gravity working against you. So aqueous is entering here, and that can actually cause the retina to detach quite quickly until the macula is also involved in the. So in this case, it's called a macula of retinal detachment. And sometimes these things can progress very quickly within a day. So the patient wakes up in the morning with a shadow at the bottom of their eyesight, and by later evening, the central vision has reduced to hand movements or counting fingers level. Interestingly, here in this picture, you can see the vice ring that I was talking about. So this patient had a rhegmatogenous retinal detachment where the PVD occurred, the vitreous separated, tore a hole in the retina, and that led to a retinal detachment. So we encourage patients who notice a sudden onset of floaters, flashing lights, and certainly if they notice a gray patch in their peripheral visual field, to attend for fairly urgent examination.
But
not everyone progresses.
Sorry, Pei, can I
Yes.
ask you? Now you have one side that is retinal detachment, right? But the
Sorry,
blurring
you
of
broke up
vision.
there.
Okay, sorry. Can you hear me now?
Yes.
Okay. I mean, blurring of vision from one side, do patients tend to not notice? Is it it's possible, right?
It's possible that they cannot notice it, especially if it's really far in the periphery. So a good marker is these blood vessels that are always quite constant. They call the arcades. So if it's beyond the arcades, yes, unless you were really quite critical as to close one eye and to look at one point and take notice, you may not notice it. So very often when patients notice it, it's usually here within the arcades. So just one patient that presented just a couple of days ago over the weekend, her retinal detachment, it was a superior retinal detachment. It had progressed, and I could actually measure the distance from the detached retina to the macula. So that was about 500 microns. So in that lady, that she needed urgent surgery. Yeah, so it is possible that patients not notice the initial peripheral visual field defect.
Okay, we go on.
Yeah, so if the ophthalmologist finds a retinal tear, this is what we normally do. It's a clinic procedure where we apply laser, and essentially what the laser does, it is spot welding and creating a scar barrier around the tear. So that prevents any fluid going in from detaching the surrounding retina. So we're not actually treating the tear per se, we're treating the area surrounding the tear. An alternative to laser would be this thing called cryoretinopexy, where you place a probe on the surface of the eye, and it's a very intense cold, localized cold reaction, and that causes scarring reaction between the retina and the wall of the eye. So again, viewer discretion advised. This is what we actually do if in the event there is a retinal detachment. So there are two approaches. One is an internal approach, which is the video that's playing. There's external approach. There are pros and cons. The external approach is when you place a buckle, a silicone band around the eye to press the wall in to meet the detached retina. In the internal approach, the first step, once you've gained entry into the eye, by the way, the little ports there to gain entry into the eye is about 0.9 millimeters in diameter. So you do a vitrectomy to clear the jelly. So you relieve the internal traction. Then you flatten the retina. So in this case, this patient has what we call a giant retinal tear. There's a tear that extends from about 1 o'clock up there all the way down to about 6 o'clock. So once you get the retina flat, you laser the retina. And the final bit is to apply tamponade, which can be a gas bubble, and that keeps the area dry until for about 2 weeks.
Oh my God. So
Yeah, and
there's no
at the end, you
vitreous-
just remove these little ports.
there's no vitreous, what do you call it? Jelly inside the eyeball at that moment.
No. Yeah, so remember the vitreous is redundant.
Okay.
So a lot of us think that removing the vitreous, the eyeball will just collapse. But no, actually the eyeball has its internal rigidity. On top of that, there's internal fluid, there's aqueous being produced by the ciliary muscle under here that fills up the whole eye and gives the eye its shape. So the gas bubble will disappear over a period of 4 to 6 weeks, depending on the type of gas bubble we use.
So your tamponade.
But that's usually
is
enough
a gas
time to
bubble.
allow the laser to set, if you like.
I see.
Yeah.
So your
So sometimes
your tamponade is actually a gas bubble?
it can be a gas bubble, it can be silicone oil. So sometimes in very severe cases, I believe in this case, because the tear was so big, I use silicone oil. So that's here you can see the silicone oil pouring into the eye. Here, there you go. So that's replacing it, and then you just remove the ports at the end. In most cases, you do not need to suture this. So it's actually remarkably minimally invasive.
But the green thing, that sheet there is going to be removed at when? This one, yeah.
Here at the end of the surgery. So
Okay.
this was actually like there you go. So it's actually a metal tube that goes in. There you go. So it's called a trocar. So these are like the trocars that the general surgeons use to enter the abdomen, but on a much smaller scale.
Oh, almost like your chest tube last time.
Yes, but this is my finger for scale, so
Yes.
much smaller. Yes.
Yeah, of course.
Yeah, and so in the past, before these small gauge systems were introduced, you would have to open up the conjunctiva a bit like this to expose the sclera, actually make a physical wound in the sclera, and consequently at the end, the wounds would have to be sutured. So that's a retina flapping forward because the tear is so big, and
So
that's
you need
I'm
more than
using-
one trocar?
Yes, so I'm holding a light part in one hand, and then I'm using the other instrument here to cut. So
I
this
see.
is called a cutter because it has it's a very clever piece of machinery invented by a person called Robert Macimer, and it's got an internal, in this little opening, there's a spinning disc, there's a spinning blade. So it's aspirating and cutting. So if you imagine, it's sucking the vitreous in, and then the rotating blade acts like a guillotine. Yeah, but that's happening at the is about 20,000 cuts per minute per second.
Oh, so
Yeah,
interesting. Also, there are three different
it's
gadgets.
nice, isn't it? Very elegant.
So you put in 3 different gadgets. One is for lighting,
Yeah.
one is for sucking.
So that's a vitrectomy.
Okay. You cannot hear me, no? Can you hear me?
I can, yes.
Okay, fine. Okay.
Yeah. So then moving on to the other part, the business and the retina. So this central little this optic nerve here, the diameter is 1.5 millimeters. So our macula, this 1.5 millimeter area here, is responsible for our central vision. So it's what, and right in the very center, in about 500 micron area, right in the center of the macula, is what we call the fovea. And the fovea is where we get color vision, contrast sensitivity. So if you had any issue with the macula, this is what you get, a permanent fixed central visual field defect. So looking at pathology of the macula, do not quote me, but anecdotally, I have read that if we all live to 130 years old, we would all look at the world like that. Because there is constant degeneration of the cells underlying the retina, and that's called dry macular degeneration. And dry age-related macular degeneration, to use its full name. There's no active intervention apart from, although these days we do understand the important role of cessation of smoking, antioxidants, lutein, zeaxanthin. And if you go to any pharmacy, there are probably 10 or 20 different types of eye vitamins with lutein and zeaxanthin. And I'm commonly asked, which one? I don't have any financial incentive from Bausch & Lomb here, but I just put this up because the most important part is to look at this thing called the AREDS2 formula. So the only clinical trial which showed any benefit of any of these of taking a tablet to delay the onset of wet macular degeneration is a trial called the AREDS trial. And AREDS2 formulas just means that it's a concoction of high-dose vitamins, including lutein and zeaxanthin. So if you're going to take any vitamin at all for macular degeneration or prophylaxis, I would suggest that you look for a preparation which follows the AREDS2 formula. Dry macular degeneration is important to recognize, even though we cannot do anything about it, because in about 10% of individuals, it can progress on to wet macular degeneration. And it's thought the underlying process is an age-related degeneration of these retinal pigment epithelium cells, and the degeneration results in the body's attempt to regenerate and heal, but it's misguided growth of new blood vessels. And these new blood vessels are very fragile. They bleed into the retina here, and ultimately it causes scar tissue formation and loss of central vision. So one of the earliest signs, so if we see someone with dry macular degeneration, I usually tell patients about the possibility, I counsel them what wet macular degeneration is, talk to them about AREDS2 formula vitamins, and also give them this thing called an Emsler grid, and advise them to monitor for any distortion and or scotomas. And it's important to check this monocularly. So cover one eye in turn and ask the 3 questions. Can I see the central dot? Can I see the lines? Are the lines straight? Are they missing? If they are, then patients need to attend urgently. In the past, this is the reason why in the past, wet macular degeneration was not treatable. I still remember when I started ophthalmology and I went up to my consultant in 2002 and told him, this patient has wet macular degeneration, and he handed me a blind registration form. So even as early as 2000, the early 2000s, there was no active treatment. The only available treatment was either thermal laser, where you burn the lesion. But what if the lesion was smack bang in the center of the macula? Then in about 2002, 2003, PDT laser came on board. But really what's changed macular degeneration treatment in the last 15 years or so is the introduction of these intravitreal anti-VEGF injections. So anti-VEGF, VEGF is a chemical that is upregulated in macular degeneration and is probably responsible for upregulating the formation of the new vessels. So, suddenly we went from nothing, no treatment or no good treatment, to sort of slightly better than natural history. And now these days, we talk to patients about a 90% chance of maintaining their vision, with about a third of them actually improving. So when I say maintaining vision, so this is very important because we cannot restore what is lost. So that's why it's even more important for patients to monitor. So the earlier you catch this, the higher the chance of maintaining vision. The caveat with these intravitreal anti-VEGF injections is one injection is not enough. You need a series of injections, and it's lifelong treatment. So, for example, look at this patient. She got injection 1, 2, 3, and then subsequently we tried to extend it out. But you can see after 3 injections, the vision here had actually improved to the driving standard, and that subsequently maintained into the year. And his patient is undergoing 8 weekly follow-ups.
Oh, very interesting, huh?
Yeah. So the intravitreal anti-VEGFs, they'll come up again later on in the topic in the talk, because this is a drug that has really truly revolutionized how we treat macular disease now. So other pathology, remember our old friend, the posterior vitreous detachment. So as the vitreous separates away from the retina and away from the macula, so that's the other thing here. So this picture here that I'm showing, I'm pointing the cursor at, this is called an OCT scan. This shows the individual layers of the retina in profile view. So if you imagine that's the vitreous, and that's the surface of the retina, there's the deeper layer, the retinal pigment epithelium, and the choroid. I'll talk a little bit more about the OCT, but it really has allowed us to visualize what is really happening in the retina. So this is when we are younger. The vitreous, as you can see here, is actually attached to the retina. Then the PVD occurs. Now, in 10% of patients above 60, as this PVD occurs, strands of vitreous are left behind at the retina, at the macula in specifically, and they proliferate. So they proliferate and they form this membrane on the surface of the retina. And it's not a very good picture here, but there's a little sheen on the surface of the macula, which we see in 2-dimensional viewing. And you can see that the vessels here are a bit crazy. They're very craggy, So there's crunching up, if you can imagine, there's crunching up of the retina underlying this epiretinal membrane. So patients can present with blurring of vision, but when you actually ask them in detail, what do they mean by blurring? They actually mean distortion of vision. And again, the Amsler grid will give you a clue and direct you towards performing an OCT scan. So that's an epiretinal membrane. And this is actually a childhood friend of mine who presented with a PVD. So in the initial stages, the vision was good, but you could see the vitreous starting to detach away from the fovea here, right? And subsequently, over a period of 3 weeks, it pulled more and more of the retina off until at week 3, there is actually a gap in the fovea here. And you see, finally, it pulls off completely. So the PVD completes, but now the patient was left with what we call a full thickness macular hole. And this was very disabling for her because she now has a central area missing in one eye. And so that upsets her stereoscopic vision. So she can't drive properly, she can't park properly. And so this is what we call a full thickness macular hole. You can see the piece of retina that was here before having been pulled away. And in most cases, it occurs for no apparent reason. Sometimes it can occur following retinal detachment surgery, because remember, during retinal detachment surgery, we are pulling on the vitreous to detach it away from the retina to relieve the internal traction. High myopes are more susceptible to macular holes, and sometimes you get these in trauma. So, apologies, there's a video here. So to those sensitive viewers, please avert your eyes. So again, we do a vitrectomy, and this is the part where we actually go in. So I've already put a dye in to stain the membrane. And this is me peeling the membrane with a very fine pair of forceps. And this, if you think about it, the fine line between, there's the membrane coming off. So the idea is to grab the membrane without touching the retina underneath it, because the retina is very fragile. So even a little touch can actually cause a tear in the retina. And definitely avoid touching this structure called the optic nerve, because if you do that, you can actually blind the patient. So following peeling of the epiretinal membrane or the internal limiting membrane in the case of a macular hole, sometimes certain patients are asked to posture face down. Usually this is done in cases where the macular hole is very big. And the idea is that the gas bubble that you put at the end of the vitrectomy and membrane peeling will then float upwards and help to press the retinal tissue together. I don't always advocate this because, to me, I think it's not super important that they posture. Studies have shown that for macular holes that are very large, or in redo macular holes, then you would advise the patients to perform this posture. Because imagine trying to adopt this head-down posture full-time, day and night, for 1 week. But the results are very good. So on the left here, this is a patient pre-vitrectomy for epiretinal membrane. Following the membrane peel, you can see the contours of the fovea have now re-established, and that's at 3 months. Although usually I counsel patients that it can take a further 3 more months, so 6 months in total, before we know the true extent of recovery. Patients are usually very grateful if their initial presentation was distortion of vision, because doing this procedure, you can have a slightly craggy looking retina such as this, but patients notice a huge improvement in their distortion symptoms. Whereas patients who present complaining, oh, my vision is blur, and you see an epiretinal membrane, you would think, oh, the epiretinal membrane sits on the macula and therefore it filters out the amount of light entering the retina and hence causes blurring of vision. But generally, I find patients who present complaining of true blurring of vision and you do their membrane peeling, they're quite underwhelmed. So the patients that are really pleased are the ones who actually physically complain of distortion. This is a patient who presented with a macular hole, and you can see in her case, within 10 days of the surgery, the hole had closed. So you can, at high magnification, you can see the junction where the retinal layers have met together. This is a little defect that still hasn't closed up. I've been following her up for the last 4 months now. But there's a huge improvement in the vision. This is driving standard vision. And in fact, her last follow-up at 3 months post-op, she had 20/20 vision, almost back to perfect vision. So moving on to diseases of the retina, I thought I would talk about diabetic retinal disease in an entire talk in itself. So Betty, if you wouldn't mind letting me know if my hour is up or my 45 minutes are up, because diabetes and the eye can take up a whole weekend seminar in itself.
Yeah, I
So
think we stop here, and then I'll
Yeah.
give you, maybe if you don't mind, another date to come back to speak about this.
okay,
Yeah, because we are
yes,
almost up for the hour.
I see. Okay,
Yeah,
right.
we've done 50 minutes. And then
All
we
right. Okay, I wasn't
we
aware
need-
of that.
Yes, and we need to take some question. So I will start off with how does the vitamins and the supplement help with the macular degeneration?
Sorry, I think you got cut off. So
Okay, I'll ask. Can you hear me now?
yes, I can.
Okay, so how does this vitamin and supplement actually help with reducing macular degeneration?
So what the clinical trial, what the AREDS trial showed was, we don't know if someone does not have wet macular degeneration, we don't know if the supplements actually help. So that means if the patient had macular degeneration in both eyes, this trial did not answer the question of whether or not it could help to prevent wet macular degeneration. But what it did show for patients where they had lost one eye already to wet macular degeneration, the trial showed conclusively that taking these vitamins could prevent, could slow down, statistically significantly slow down the development of wet macular degeneration in the second eye.
Oh, that's funny. Then in that case, it should show that it's preventive in both eyes before it can happen. Before it happens.
Yeah, I did ask that question to to various individuals. I think it's to do with the ethics of withholding a potentially beneficial treatment when doing a trial, a clinical trial. So
it's
if you
so it's actually what they have done is they have done it as a secondary prevention, correct or not? Means
yes,
secondary
correct.
prevention in a patient with macular degeneration. But there is no trial or no result that is beneficial in primary prevention. No
In
trial.
primary prevention, no, not that we know of
I
currently.
see. Okay, so there is a question Dr. iPhone asked. Is cataract reversible if patient decide to leave the cataract till the vision is severely blocked, only to do surgery? Reversible is
I think maybe what you mean is operable. So yes, in the past, we used to have this concept. You may have heard, "Oh, my cataract is not ripe yet," or "may soak," you know.
Okay.
So in the past, patients used to wait, or patients were told to wait until this level. Now it boils down to the surgery itself. So remember, I said phacoemulsification. So it's a small wound, and this high-speed ultrasound breaks up the nucleus. Now, if the nucleus was very tough, then sometimes you cannot phacoemulsify the nucleus. So in these cases, you would have to revert to the old style operation called an extracapsular cataract extraction. So in these extracapsular cataract extractions, you actually make a very big wound stretching from say about 11 o'clock, 10 o'clock, all the way to 2 o'clock. And so you almost flat open the cornea, you make a big hole in the capsule, and you squeeze the nucleus out like a pimple before putting a new lens in. But that would mean suturing the cornea at the end of it. So yes, you can leave cataracts until this stage, and even beyond. I'm actually doing one at the end of this week where it's not even yellow or brown, it's just almost black. So in that case, I'm going to try to do phacoemulsification, but ultimately I accept I will probably need to do an extracapsular cataract extraction. So it's reversible, it's operable, even at this stage and beyond.
So how
But
long
I wouldn't encourage it.
how long is the operation of the previous this operation compared to your phacoemulsification?
So again, it falls into experience. When I started eye training, we did phacoemulsification from the beginning. So in fact, I had to go to India on an eye camp to learn how to do extracapsular cataract extraction. And
oh, I see.
Yeah, so they were very fast. So it can be very fast. But in my hands, I would say comfortably under 1 hour.
A lot more than 12 minutes.
Yeah, yes, I would say so. Yeah.
Yes.
Because sometimes in very severe cases, as you squeeze out the nucleus, some vitreous comes along. And if vitreous comes along, then you've got to close up and then you've got to clear the vitreous first. So usually if I'm planning to do an extracapsular cataract extraction, I list the patient for 1 hour just to give myself time to do a vitrectomy if needed. But
it's still done under local, right?
Yes, you can do it under local anesthesia.
Okay, so Dr. Sivandan from Docquity asks, is there any eye drops available to arrest cataract from progressing?
There's a lot of work into that. And as yet, there's no evidence to suggest otherwise. So the short answer is no, not at present. But there's a lot of work being done to put us out of a job.
Okay, so what actually happens in the cataract? What's the material that deposit into making it a cataract?
It's collagen. It's collagen and some, oh gosh, this is going back to my part 1 basic ophthalmology,
okay.
delta crystallines and things like that. So essentially, the lens is composed of lamellar sheets of collagen and proteins. And what happens is there's denaturation of these proteins. So there's disruption in the lamellar structure. And so the lens becomes opaque over time.
Now, when you do this operation, the operation is covered by insurance, right?
Correct.
Is the lens covered by insurance?
These days, a monofocal lens is covered by insurance.
I see.
So because insurance companies take the stance that wearing glasses is not a medical condition. So they will pay for the cataract and a monofocal lens, but anything beyond a monofocal, even a toric monofocal to correct astigmatism, the patients would have to pay for it. So a multifocal toric lens implant is definitely not covered by insurance. And despite what a lot of insurance agents say, no, it does not depend on what the doctor writes.
Okay. Do you mind if you stop sharing? Because I need to share the how you call that? The QR code for the doctors for CPD points.
Okay, thank you very much for everyone.
I got some more questions.
Oh, okay. So I will stop the share.
You just stop the share, and then you also
okay.
you can also what? you can also, okay. So if anyone wants to buy Dr. Shield, stop. Okay, why is my share always paused? Okay, hold on. Okay, use Hearts 2021 for 5% discount. And then, okay, this is a QR code for doctors. You can also scan with your MMA app pay, and you get 1 CPD point. We do it. Now, if for the foreign doctors, actually, I can give you the e-cert. I'm working on it. Okay, there's one more question, which can you see the question? Okay, I can see it now. Any supplement to slow down or stop cataract progression? Can we suggest patient take collagen or protein?
There's no evidence based to suggest there's anything that can stop or arrest the development of cataract.
But can you tell us what are the risk factors for cataract formation so that we can actually maybe work and stop that risk? I know one is steroid, right?
Steroids, yes, steroids, and especially topical steroids. So a lot of patients with eczema or psoriasis, you know, they got to be very, very careful about instilling the cream, you know, wiping the cream around the eyelids and the facial skin. Yeah, so that is something that's very common. The other thing that also patients have to be aware of is topical steroids, eye drops.
There's a sound here. Oh, topical steroids.
Yeah, so a lot of eye drops on the market. And unfortunately, I've actually come across this situation where I've been in a pharmacy buying some prescription tablets, and you know, next to me, a patient is being handed out eye drops because they had approached the pharmacy and said, "Oh, my eyes are itchy," and they were given these eye drops, and I remember the instruction: you just take whenever you feel itchy and just carry on, you know. And I looked across, and it was prednisolone, you know, and it was quite shocking. Yes,
it will create a lot of work for you, though.
Unfortunately, but unfortunate for the patient. Yeah, that's the trouble. Yeah.
Okay. Christina asked whether is it possible to get a talk for you for glaucoma. Okay, our friend here, Dr. Pei, is actually a retinal surgeon. That's why he loves it.
Yeah, it's a bit like asking a car mechanic to talk about motorbikes, you know. I could tell you the basics about open angle glaucoma, but I think the person to talk about it would be my glaucoma colleagues, Dr. Lim Xian Han or Dr. Lim Lei Ai. Yeah, they're probably the content experts. I just dabble in it. My retinal surgery mostly causes glaucoma, and in which case I referred to them for help.
Yeah, the problem is we are also subspecialized. I will see. Actually, today's topic is already very vast and very you know, can cover so many things. But you really didn't cover glaucoma. You didn't even mention a single thing about glaucoma.
Correct. Yes. Yeah. Because if you think about 30% of ophthalmic work comes from retinal issues, and another 30% would come from glaucoma, which is a silent disease. And I think glaucoma deserves its own.
Okay, I will try to arrange for a glaucoma talk. But
Yes.
you see, a lot of the people that I managed to get speakers from are people who are chit-chat in a doctor's lounge. So if they don't come to the doctor's
Yes.
lounge, I do not know
The
them.
Breakfast Club.
Yeah, all of us are always there at the doctor's lounge, just chatting. So yes, they're so nice to do me this favor to give the talk. Okay, I'm going to stop
Pleasure.
recording now.